everyone. I'm one of the PGY2s, and I have the great honor of announcing our awesome speakers today. We have three of them. The first speaker is George Sanchez, and I asked them for a fun fact, and I gave them absolutely no kind of guidance on that. So his fun fact is that he eats the skin of kiwis. You can't make this stuff up, folks. So this is George Sanchez, and his talk is titled Orbital Mucormycosis, Diagnosis and Management.
Yeah. Thanks, everybody. Yes. Fun/weird fact for sure. So today's talk that I'm giving, it's on Mucor. The reason I wanted to give this talk is because I remember when I was a more junior resident, I was always scared of missing this sort of diagnosis. And so for the more junior residents in the room, I wanted to kind of discuss this, talk about the case that I saw on call about a month and a half ago, go into a couple more cases, and then just delve right into all the details related to Mucor. So just to get started. So no financial disclosures. And so here's just like a guide to all the topics I'm going to be covering today. So just a case series at first, some characteristics, pathophysiology and diagnosis, management, and some take-home points. So just to get right into it. So this is the case that I saw about a month and a half ago at Huntsman Cancer Hospital. And just to give you a sense of what I walked into, so this was the patient at first glance. As you can see, just some periorbital swelling and erythema around that right eye. And then a little bit of a close-up on the image on the right. We see that maybe there's some hemosis and then a pterygium. And when I ask him to do EOMs, you can see right gaze, left gaze are full. Down gaze also full. With some hemosis there, but as I asked him to look up, he has a superduction deficit there. And then so on his exam, he's actually 20/20 OU. Pressures were normal, no APD. He did have that deficit as he looked up on that right eye. Some swelling and edema and erythema around that right eye, and some trace temporal chemosis, but notably, his optic nerve was not swollen. He had no dysfunction of the optic nerve on that right eye. And so just a little bit of background for this patient. So he was 56. He was coming into the Huntsman with a history of CLL. He was on immunosuppression medication 20 days prior to coming into the Huntsman. He was seen at a hospital in Nevada for a temporal lobe mass. And he actually had undergone a craniotomy to resect this mass. That mass was felt to be infectious in nature. It grew gram-positive cocci in clusters, and so he was on a range of antibiotics. When he came into the Huntsman and I saw him, he came in with fatigue, right eye swelling. He had denied any sinus symptoms, so no purulent nasal drainage, no sinus pressure, nothing of that nature. And so when I saw him, the Huntsman team, the primary team, was already going to do an MRI brain. I didn't ask them to do this. They just got this done. And as you can see, the impression on the MRI was a lot of stuff related to the fact that he just had surgery, things like swelling and postoperative changes. But notably at the bottom, I included the part where they mentioned the sinuses. And all that was mentioned was mild scattered mucosal thickening of the sinuses with bilateral lens replacements. But nothing else was commented on the sinuses. So I actually called the neuroradiology fellow and asked him to take another look at the sinuses. And so they made an addendum to the MRI. And they did say that, basically the sinuses were eroded. There was a lot of changes consistent with maybe invasive fungal sinusitis. And so ID was consulted the very next day. And interestingly, I actually did my intern year with the ID fellow. And so the ID fellow and I chatted over the phone. He actually reached out to the outside pathologist in Nevada who, did the pathology for this case. And there was actually some concern that maybe the gram-positive cocci was a source of contamination and not real. And so the decision was made to send the brain slides over to the U for fungal staining. And he had commented in the note that the patient was an unusual host for Mucor, just because of the fact that he wasn't neutropenic, but there was likely impaired neutrophil activity because of the CLL. As you can see on the right, this was his blood work here, and the white count was 60, but of course he has CLL, so there's probably a functional component that was at play. The fungal staining did come back negative for the brain slides. And then, unfortunately, the very next day after I met this patient, when I met him, he was alert and oriented. But the very next day, he developed optic disc swelling on the right. He had anisocoria. He was altered, not oriented. 5 days later, he was encephalopathic, not following commands, and he was unable to participate in an eye exam. So over the course of his week after I met him, he did receive 3 amphotericin retrobulbar injections. He underwent debridement with ENT and had IV antifungal treatment, but unfortunately did pass away about a week after we had originally met that day. And then just to move on to the second case, this is a case that was shared with me with Dr. Dustatel's actually shared it with me, Jordan. And so this is a more classic case of mucor that we all know. So this patient, when he came into the U of U hospital, had periorbital swelling and erythema. As you can see, he had a blown pupil. The pupil was very dilated, some chemosis. And as you can see in the bird's eye view, very mild proptosis, but on right gaze and left gaze on the bottom, he had ophthalmoplegia, so inability to just move the eye whatsoever. And his history, so he came in, he was already in DKA coming in from this outside hospital. As you can see, the blood work, he had an elevated white count. His bicarb was low. He was on a range of antibiotics as well as antifungal treatment. He came into the U for further care. His exam, so he was 2400 on that right eye. His pupil was fixed. He was completely ophthalmoplegic, unable to move the eye. He had edema, mild upper and lower lid edema. And then notably his disc was, did have some inferior and superior elevation to it. And then just a point about his optic nerve exam. So mucor invading into the eye itself is exceedingly rare. It's likely related to the fact, his edema is likely related to the fact that he had an orbitopathy, or just so much going on with the mucormycosis invading into the sinus and into the intraconal space that all that caused axoplasmic stasis. And that was likely related to the fact, or what led to the fact that he had that disc edema. But it wasn't that mucor was invading into the eye or anything like that. So that wouldn't be a reason to pursue exenteration. But that's just something interesting to note for this patient's case. And so the final outcome for this patient, so he did have 2200 vision. His motility didn't improve. He did receive a total of 10 retrobulbar amphotericin injections without any complication. But the decision was made to pursue comfort care, given that he had cavernous sinus involvement and he didn't improve. And so this case was a case from UCSF. And Dr. Kirsten shared this case with me. And so I'd like to thank him for sharing this one with me. This was a patient who was 68 at the time that Dr. Kirsten met him. This was back in 2015. He had come in with right eye pain for the previous 10 days prior to his presentation. His past history, so he had idiopathic pulmonary fibrosis. He had undergone bilateral lung transplantation in 2015, so earlier that year. And he was on a range of immunosuppression medication, so tacrolimus and prednisone. When he originally was seen, his vision was normal, both eyes. He had no APD. His exam was really reassuring. And the MRI did show no evidence of intraorbital pathology, just some some sinusitis on the right side, some abnormal hyperintensity along the right anterior cranial fossa, but no orbit involvement. And so ENT did perform fast. They did a biopsy. It did confirm mucormycosis in this patient's case. The exam did change, however. So by hospital day 11, 7 days after the diagnosis was made, his vision did change to 20/70 in the right eye. He had an APD, and his color vision went down on that right eye. And so an MRI was done, and it showed progression of the mucormycosis. So there is new enhancement along the right medial orbital wall. And as a result, a discussion was had with the patient regarding, what should be done? Should we just observe? Should there be some sort of globe sparing intervention? Should we pursue exenteration? After a lengthy discussion with the patient, he's kind of against the idea of doing a surgical intervention. So the decision was made to pursue a globe sparing intervention, just because the transplant team at the time was hesitant to pursue something more extreme, given that the vision was 20/70 and he had a fragile pulmonary status, as he did receive a lung transplant earlier that year. And so he did undergo a series of 3 injections of retrobulbar amphotericin. This is on days 11, 12, and 13. And as you can see on the right, by day 17, so 4 days after he completed this series of 3 injections, his vision did improve to 20/20 from 20/70. That APD did go away. He still had some restriction in eye movement, but he did have an improvement in his exam. And then 2 days after this, so this was day 17, by day 19, he noted that a scotoma had appeared in his vision, and the vision actually went down to 2200 now, and APD did return. So again, he had a decline in his exam. Again, the decision was made to re-pursue amphotericin retrobulbar injections, and so he underwent a series of another 3 injections on days 19, 20, and 21. And then by day 36, he had a normal exam. His neutropenia had resolved. 5 months post-discharge, there is complete resolution. So another MRI was done. There's complete resolution of abnormal signal on the MRI. His exam was 20/20 in both eyes, no APD, full EOMs. He had a complete resolution with these retrobulbar injections. And so my next point that I wanted to talk about was just an overview of mucormycosis, patient characteristics, pathophysiology, and diagnosis. And so this is the largest case series in the literature for mucormycosis, a total of 929 cases from the late 1800s to 2006. And the interesting part here is that they break down all the cases by underlying condition at the time of diagnosis. And so most commonly, 36% of all cases was related to background diabetes, but malignancy and solid organ transplantation were the next 2. So it's not just, I know in medical school, we learned that diabetes is the classic association of mucormycosis, but there's other things at play that you have to be thinking about mucormycosis in patients who are overall immunosuppressed, whether that's malignancy or solid organ transplantation. The interesting point here is that when you break it down by underlying background disease, the area of involvement with mucormycosis changes. And so with a diabetic, rhinocerebral involvement is by far the most common thing we see. But with someone with malignancy, rhinocerebral and sinoorbital involvement are exceedingly rare, 5%, 4%. Pulmonary involvement is much more likely. And someone with a transplant, again, pulmonary involvement is much more likely. Rhinocerebral and sinoorbital involvement of the disease is exceedingly rare in these kind of patients as well. And so with the pathophysiology as to why or how mucor invades into our body or into a immunosuppressed patient's body. And so in a normal hostess case, there's a lot of things at play that prevent this from happening. So iron binding proteins in the serum do not allow iron to freely roam around in the serum. And so that along with neutrophils and macrophages prevent infection from occurring, and the endothelial cells regulate permeability as well. But in a susceptible host, someone with diabetic ketoacidosis where the bicarb is low and there's an acidic pH at play, that causes dissociation of free iron, and the iron binding proteins can't do their thing. And mucor actually feeds on iron. That, along with the fact that a patient is likely neutropenic and there's functional deficits to the innate immune system as a result of being in diabetic ketoacidosis or having an underlying malignancy or solid organ transplantation. All these things allow the fungus to roam. And then the fungus invades through an angioinvasive process. And so that breaks down the endothelial cell protection, and that damage also allows the fungus to grow. And so this is kind of key. The iron dysregulation is really pivotal in the pathogenesis. And interestingly, deferoxamine is an iron chelator. And after diabetes, malignancy, and solid organ transplantation, the 4th most common underlying condition that we see associated with mucormycosis is deferoxamine use. Patients with hemochromatosis or iron overload from excessive blood transfusions, like a sickle cell patient or a thalassemia patient. So as we can see, 6% of these 929 cases, or 53 cases total, were associated with deferoxamine use. And an interesting clinical aside, so during the COVID-19 pandemic, Mucor saw a rise globally. And the reason why that was is that these predisposed patients who ended up getting COVID-19, diabetics, for example, were getting corticosteroids as part of the treatment for COVID-19. So that kind of combination of predisposed patient with diabetes getting steroids for COVID-19 ended up developing diabetic ketoacidosis, which allowed the mucor to grow, and it was like a perfect environment for the mucor to grow. As well as COVID-19 was associated with just more free iron in the serum. And so all of that led to just a rise overall in mucormycosis cases associated with COVID-19. So why does the underlying pathophysiology matter? And so why it matters so much is because it really determines mortality. So a diabetic who comes in with DKA has a much better chance of surviving mucormycosis than someone with transplantation or malignancy. The ability to reverse the immune dysfunction is key to being able to survive mucormycosis. And then again, just to kind of point out this table from the largest case series in the literature, 176 patients in this case series actually didn't have a underlying condition. They ended up getting mucormycosis in the setting of trauma or surgery or a bad burn. And this mortality rate was much lower compared to patients who had some sort of immune dysfunction at play. And so the next point I wanted to talk about was management of mucormycosis. So the principles of how we manage mucor is, number one, we try to reverse the immunocompromised state, whether that's DKA, we try to address electrolyte derangements, things of that nature. And number two, we do IV antifungal treatment. But then the third point, and it's really a contentious point in the literature, is whether to pursue surgical debridement versus exenteration. And so this is a paper that came out in 2006 related to whether or not to pursue orbital exenteration and the indications for it. And in the paper, the inspiration for why the paper was written was because the lead author had a case of an 18-year-old with diabetes who had mucormycosis. And kind of the ethical dilemma was, should we pursue exenteration and maybe that's going to improve the survivability in this patient's case? Or do we not pursue it and it's not going to make a difference? What are the factors at play that, kind of guide us to that decision? And so they reviewed the literature for cases of mucormycosis and what kind of led to improved survivability when exenteration was pursued. And so 292 patients were reviewed, and exenteration didn't demonstrate a clear benefit. Maybe there was a benefit when there is a fever at presentation. And so we can see on the table on the right, exenteration wasn't related to an increased survivability, but with fever it was. But that kind of there's a bias at play there. Maybe there was more systemic infection. And so to kind of have better control of the infection, exenteration was pursued in those patients' cases, and that could have led to improved mortality. But again, it was not a clear benefit. Out of the other point the paper made was they surveyed actually the ACE-OPERS preceptors, and 26 out of the 34 at the time responded to the survey. And the survey was around mucor management. And so 26 out of the 34 responded. 70% of the mucor patients that these 26 preceptors saw were in the last 5 years. Most of the preceptors had only seen 2 or 3 cases, and 39% of those cases underwent exenteration, with 55% of them surviving. Overall, the criteria for exenteration amongst these preceptors were mixed, and there was no clear indication when to pursue exenteration. So that kind of leads me to my next point, which is retrobulbar amphotericin treatment. And so I wanted to share this paper that was written by our very own Dr. Kirsten. And so this was back in 2022. And the goal of this paper was to address the question whether or not retrobulbar amphotericin reduces the risk of exenteration without compromising survival. And so basically, when we do retrobulbar amphotericin, does that decrease the risk of having to pursue exenteration, and does retrobulbar amphotericin lead to a compromised mortality for these patients? And so 50 patients with biopsy-proven invasive fungal sinusitis were reviewed. Retrobulbar amphotericin was incorporated into the treatment paradigm at UCSF in 2015. And so 20 patients pre-2015 versus 30 patients post-2015 were reviewed in this case series. And so a stepwise approach was used for determination of, whether to pursue observation versus a retrobulbar ampotericin injection versus debridement versus exenteration. And a combination of imaging and exam findings were used to kind of make that determination. So imaging, as you can see here on the left, if it was just mild enhancement, kind of subtle, with a normal exam, that decision was made to just observe that kind of patient. But if there's any sort of abnormal findings on the exam, even despite having just subtle findings on the imaging, they would pursue a retrobulbar ampotericin injection. If that imaging progressed to the point where it was moderate and diffuse or apical, again, retrobulbar ampotericin. If it further kind of progressed to the point that there is a surgically accessible area, it was moderate enhancement, conservative debridement was done. But if there's loss of contrast enhancement completely with a severe and diffuse nature and an abnormal exam, then exenteration was pursued. So it was a very stepwise approach to whether or not, what kind of treatment to pursue in each patient's case. And just because I've alluded to this earlier in the talk, the underlying diagnosis, the disease severity, cavernous sinus involvement, all those things kind of determine the likely outcome for the patient. Between the pre-2015 and post-2015 patients, there is no difference in underlying diagnosis at play, disease severity, cavernous sinus involvement, or intracranial involvement. There is no difference in baseline visual acuity or motility, and no difference in ability to reverse the acute immunosuppression. And so, as kind of I've already discussed earlier, but whether the patient has diabetes or an underlying malignancy or transplant, all these things determine how likely the immunocompromised state can be reversed. And that determines the overall mortality. But in these patients, in these two cohorts, that kind of difference was negligible. It was not significant. And so the pre-2015, post-2015 kind of comparison. So exenteration was much less likely in the post-2015 patients' cases, so less than 10% of the time, versus pre-2015, over a third of patients were exenterated. The mortality was no different, about 40%, regardless of exenteration, better final vision in the post-2015 group, and a 4.3% complication rate. And so I think the paper did a good job of answering that question, that retrobulbar ampotericin does decrease the risk of exenteration without compromising survivability. And so just kind of a couple take-home points here. So a wide range of presentations with mucormycosis. Therefore, you kind of need a high index of suspicion whenever something seems fishy. Mucor has a variety of presentations consistent with different background disease. The reversibility of the immunocompromised state definitely determines how likely the patient is to survive. Exenteration is unlikely to change mortality, and a retrobulbar ampotericin injection has a good chance of having to avoid exenteration without compromising survivability. Thank you so much.
Some of you missed George's fun fact, which is that he's the skin of kiwis. I need everyone to know this about him, so. All right, so thank you so much, George. I really appreciate your talk. Next, we're moving on to another one of my superstar co-residents, Dr. Erica Woertz. And her fun fact is that she was in the marching band in high school. She was in color guard for 3 years and played the piccolo her senior year, which is very impressive. I would expect nothing less from Erica. So her talk is titled New Insights and Ongoing Challenges in the Diagnosis and Management of Albinism.
I like to think that my years on color guard is how I acquired my SIGBO staff skills. Yes, great. Okay, thanks for your patience. And I'm really excited to be here. As many of you know, albinism is a topic that's near and dear to my heart. And I know this is also a topic that's familiar to this community, having had Dr. Creel here, who was one of the key people who discovered some of the classic features of albinism that we now know about. So I kind of wanted to talk about synthesizing some of the more recent findings that we're discovering about albinism and how that might change how we approach thinking about it or evaluating a patient for albinism when you're seeing them in clinic. So we'll just start with an overview of some of the things, again, might be familiar to some of the folks in this audience, but albinism is a genetic condition that causes dysfunctional melanin synthesis and or signaling. And this is important to us as ophthalmologists because it causes a lot of key changes in the development of the visual pathway. The most notable that we can see on imaging is foveal hypoplasia, which is really obvious if you get an OCT on these folks. You can see in these scans that whereas in a normal foveal development, you have this really nice foveal pit where all of those inner retinal layers are displaced away from that central vision. In someone with albinism, that foveal pit doesn't form. And that can really happens to varying degrees. Some people have a rudimentary pit, whereas others, such as in this scan, really have no semblance of a foveal pit at all. And this is even more striking if we look at a 3D rendering of the fovea. That pit really just isn't there. So this isn't a matter of not being in the right slice. It's just the overall morphology. The other thing that goes along with this is that when there is foveal hypoplasia, there's also usually not a foveal avascular zone. So if we perform OCT angiography on people with albinism, you can see whereas in a normal individual, you have this area of that inner capillary plexus that, again, is missing from the center of the foveal pit. In someone with albinism, you have these capillaries that are persistent all the way across the fovea. We also know that the optic nerve fibers in someone with albinism abnormally decussate, meaning you have more fibers that are crossing over to the contralateral side of visual cortex. And that leads to this change in the way that visual space is represented in visual cortex. Not going to be talking about that as much today, but that is relevant for some of the clinical features, which include nystagmus, photophobia, that reduced or absent depth perception, which really is a direct result of the optic nerve miswiring, as well as reduced visual acuity. And that reduced visual acuity tends to be one of the pieces that for patients can have a significant effect on their lifestyle and what kinds of resources they might need to pursue the activities that they want to. I always like to emphasize the spectrum of clinical presentation, that not everyone with albinism is going to have that kind of characteristic hypopigmented appearance that you're just going to know from across the room when they walk in. This is a figure that shows just 2 individuals with albinism. And if you look at these external photos, whereas this person on the top, it might be someone where you could look at them and think to yourself, yes, maybe I should be thinking about that as a possibility for them. This individual on the bottom row has probably pretty similar overall pigmentation to the vast majority of patients that we see here in Utah. And so you wouldn't necessarily look at them and think to yourself that this would be on your differential. And it's a similar story when you look at their fundus photos. Again, this top photo shows kind of that classic blonde fundus that we think of when someone has albinism. But in a lot of subtypes of albinism, their fundus might look completely normally pigmented. And if we look at their OCTs, this person does have that more severe or more prominent foveal hypoplasia, whereas this individual, they do have a little bit of that pit, so that's what I was referring to before, but you can see they still have inner retinal layers that are present at the deepest part of the pit, which meets criteria for them having foveal hypoplasia. In this study, they also looked at VEPs. And when you are evaluating someone for albinism, you can do a VEP in a really unique way, where instead of just recording from a single point on the occiput, you're actually recording from individual hemispheres in the visual cortex. And if you are stimulating only one eye at a time, you can basically measure how much signal is going to the left versus the right hemisphere of the brain. And that's what they're showing here with this individual, where when they're stimulating the same eye, if you measure from the left versus the right hemisphere, the traces are actually inverted or flipped. And that's kind of that sign that the vast majority of signal is going only to one hemisphere, whereas the other hemisphere is not getting those fibers from that eye. This individual still has that classic inverted pattern, but it's just, again, not quite as prominent, which suggests this person might not have the same degree of abnormal decussation as this patient, but it's still there and still characteristic of albinism. There are a lot of different subtypes of albinism as well. The more common ones that we think of are oculocutaneous albinism, or OCA, and ocular albinism. But there are a few syndromic types of albinism, such as Chidiac-Higashi and Hermansky-Poldak syndrome, which are important in a clinical context for reasons that I will go into in a moment. There's also this new entity known as FONDA, or foveal hypoplasia, optic nerve decussation defects, and anterior segment dysgenesis, which is the syndrome that basically has all of the clinical features of albinism in the visual system, but has no known changes in pigmentation. But when you're doing your eye exam, it's probably going to look more or less identical to someone with albinism. So that's why I include it here. So all of these subtypes are going to have similar ocular findings. As I mentioned, if someone who has ocular albinism might not have that external pigmentation changes, and the same goes for FONDA. Whereas with CHS and HPS, these do tend to have more systemic pigmentation changes. The important thing to keep in mind, just to have, even though these syndromic forms are less common, but it's important to have at the back of your mind, is because they do have other important systemic features that go along with them, including immune deficiency. Bleeding diathesis is a really important one, as well as in HPS. We're becoming a lot more aware of the frequency of pulmonary fibrosis in these patients. And so things like the pulmonary fibrosis or immune deficiency are things that could potentially kill a patient if it goes unrecognized or untreated. And so those are things to always be thinking of and asking about in your review of systems if this is on your differential. I'm going to be focusing for the rest of my talk primarily on OCA, or oculocutaneous albinism, and OA. I want to talk about the genetic causes of these conditions too, particularly for OCA. There are at least 5 different genetic subtypes of OCA that are all caused by mutations in different genes on different chromosomes, in addition to the gene that causes ocular albinism. And the reason that they all cause similar phenotypes is because all of these genes are involved in different steps of the melanin synthesis pathway, whether that's directly synthesizing melanin or regulating the melanosomes so that they function correctly in the cell. We think that the ocular features and kind of the changes in visual system development don't come as a result of melanin per se, but rather due to changes in L-DOPA production, because we know this is a really important signaling molecule for neurodevelopment. And this is actually also the theory behind why this particular mutation in GPR143 causes the ocular albinism phenotype without affecting pigmentation, because this is a cell surface receptor for L-DOPA that again is involved in that neurodifferentiation pathway. And so there's a lot of theories behind how all of these different genes ultimately lead to that, again, that similar phenotype, because they're basically leading into that neurodifferentiation pathway at different steps. And so depending on how far upstream the pathway is affected, you get more systemic or more severe manifestations of the phenotype versus all the way down to, this is the gene that causes FONDA, that syndrome that I brought up earlier, is really not affecting anything upstream. It's really just thought to be involved in that kind of those final steps of neural development of the retina. What we're finding more recently that I think is really fascinating is that the genetics behind albinism is really not as simple as it seems. You know, I think most of us learn in medical school that albinism is one of those examples of quote classic Mendelian genetics, right? Where you know, it's an autosomal recessive inheritance, except in the case of ocular albinism, which is X-linked. But most OCA is autosomal recessive. You get one mutation from mom, one mutation from dad. That gives you this phenotype. But what we are finding is that the phenotypes certainly transcend kind of this binary classification. And I think that even before the age of widespread genetic testing, people had this awareness. And you can see this in some of the older literature where people were trying to better characterize different types of albinism. Some of the earliest attempts to characterize albinism used these terms tyrosinase positive versus tyrosinase negative, where again, tyrosinase is that enzyme that performs the rate-limiting step in melanin synthesis, and is that gene leads to oculocutaneous albinism type 1. Because the way that they used to diagnose albinism definitively was actually to take some kind of a biopsy, whether this was a skin biopsy or they would look at terminal hair bulbs and put it under a microscope and say, is there melanin or are there melanosomes or are they not? And so this is kind of a good illustration. This is actually histology from RPE from a deceased individual who had albinism, and kind of showing this idea that even some folks who had that characteristic hypopigmented appearance, when we look at their cells under the microscope, they might still have these melanosomes present, or their enzyme assay might show that there is still some tyrosinase activity. So they were talking about, okay, some individuals are tyrosinase negative, having this really extreme phenotype versus tyrosinase positive. This led to a clinical distinction, particularly in folks who were presumed to have OCA1, between OCA type 1A versus OCA 1B, where OCA 1A refers to people who have no pigmentation whatsoever. So that would correspond to these tyrosinase negative individuals, whereas OCA 1B refers to folks who they have some pigmentation, but we're still seeing some of these features. Although what we're finding now that we can perform genetic testing and we have this so readily available to us is that there's so many mutations on each of these genes that can cause the albinism phenotype, and all of them really convey a different level of enzyme activity. So this isn't a binary, is tyrosinase active or not? It's really how active is it? And so this is actually a really old figure showing just some of the pathogenic mutations just on tyrosinase that we're familiar with. And so you can imagine that how this contributes to the spectrum of phenotypes. And so I think now most folks would say that really this distinction between OCA 1A versus 1B is not really a useful or worthwhile distinction, because everyone lies somewhere at a different point on that pigmentation spectrum. This has also led to us asking some questions about the role of hypomorphic alleles. And when I say hypomorphic, these are also mutations or polymorphisms in the gene that can affect enzyme activity, meaning that the enzyme is less active than the wild type. But if someone is homozygous for this polymorphism or this allele, it does not seem to be enough to cause them to have albinism. They might have fair pigmentation or fair skin, but they don't have albinism. You know, their retinal and visual system development seems to be completely normal. So that hypomorphic allele by itself is not enough to cause albinism. But as we'll see with some, particularly this one that I'm going to talk about, it might still play a role. So this particular polymorphism, R402Q, is one that has been really controversial in the past. This is a hypomorphic allele that causes a temperature sensitive version of tyrosinase enzyme. And what that means is that it makes the enzyme more active at a lower temperature. So it's not quite as active at body temperature, but just a slightly lower temperature than body temperature. It kind of hits its peak activity. And the way that it makes it easy to remember this is because it's actually the exact same hypomorphic allele that gives Siamese cats their characteristic coat color. So you can imagine that a Siamese cat has the darkest pigmentation in the parts of its body that are the coolest, right? So the tips of its ears and its toes and its tail, whereas the parts that are all around its core, the warmest part, are less pigmented. And this is one of those alleles that we know is not sufficient to cause albinism by itself in humans. But we have done a lot more studies of foveal development in people who are homozygous for this R402Q allele. And here I'm showing those homozygous individuals in this top row in comparison to folks who either don't have the allele or this person is heterozygous over here. And you can see that even though these folks don't have albinism, they do tend to have smaller foveal pits. And also some of them have kind of these anomalous foveal avascular zones, right? Where you're like, maybe I could hallucinate that there's a foveal avascular zone there somewhere, but it doesn't really look quite right. There's kind of some blood vessels that are trying to grow through. So this is kind of further bolster the idea that there's this dose-dependent effect of tyrosinase activity and possibly L-DOPA levels during development on how the fovea develops, and that kind of explains this wide spectrum of phenotypes. So this has kind of added this extra level of complexity to the genetics, because now we're thinking that it's possible that multiple hypomorphic alleles or polymorphisms when combined together, might have this additive effect to then create more of a prominent phenotype. And the one that folks are most focused on is a particular haplotype that combines R402Q with a different hypomorphic allele S192Y. And basically what we're finding is that if we look at some of these probands who have albinism, and certainly in this particular case that I'm showing, neither of the parents have albinism, but when we do genetics, we find that in this case, mom has this haplotype, this allele where she has both R402Q and S192Y in cis with each other. So they're on that same chromosome, that same allele. Whereas dad has a pathogenic mutation. And so this individual, it turns out, has inherited the pathogenic mutation from dad and this hypomorphic haplotype from mom. And that seems to be sufficient in this individual to cause albinism. This has led to a lot of interest to look more deeply at other hypomorphic alleles, and also has kind of raised the suspicion of, is it possible that there could be a polygenic albinism, that perhaps maybe having a pathogenic mutation on tyrosinase, for example, plus a pathogenic mutation on OCA2, which is a gene that causes OCA type 2, maybe that could be enough to give you the overall phenotype that maybe, again, doesn't fit neatly into one of our categories. And the reason people are really interested in this is because people with albinism or with a clinical phenotype consistent with albinism really only have about a 50% genetic diagnosis rate. So even for folks who we see them in clinic, everything, it looks like albinism, it acts like albinism. We do their genetic testing and we might find one pathogenic mutation, or we might find no pathogenic mutations. And so there's certainly a lot of room to discover more about additional mutations that we haven't identified, and also kind of understand more about how these different polymorphisms all interact with each other to reach that final phenotype. Because the genetics are so complex and not always especially informative, we've also led to this point of trying to define some diagnostic criteria. This is one paper who had proposed some criteria where even if someone doesn't have a genetic diagnosis, you can look at their clinical features and say, okay, how there are some major criteria as well as some minor criteria kind of in combination. Can we make a more definitive diagnosis? I think one of the things that I don't like about this particular model is that they include optic nerve misrouting as one of their major criteria, which is certainly one of those classic features of albinism. But I think the way that this algorithm works sometimes kind of puts you in this weird position where if you have a patient who doesn't have a genetic diagnosis, you almost have to get a VEP and prove that they have misrouting, which at our center, we're really privileged that we can order that for most patients. But certainly not every center has that. And also if you have a young child, you're not going to want to put them under anesthesia to do a VEP just to confirm their genetic diagnosis. So I think there's a lot of room to kind of expand this algorithm and add some other clinical features. So when you have a patient who has albinism, or you think you might have albinism, there's a few management considerations that I would propose that I know a lot of folks in this room, again, are familiar with and do routinely. First is to do a thorough review of systems, because as I mentioned before, a lot of patients might have one of those syndromic forms, and that can be really important to identify early and make sure that you're referring them to the right individuals to manage and treat. I've actually had a few patients participate in research who previously had not ever had genetic testing and just thought they had albinism and nothing else was going on, and turned out to have Hermansky-Pudlak syndrome, which has a lot of important bleeding abnormalities to know about. So certainly ask about easy bleeding, easy bruising, if they're getting sick often, those sorts of things. Certainly make sure that you're getting their refractive error corrected. A lot of these folks have really high refractive error, both high myopia and high hyperopia. In kids, that means it's really important to treat their strabismus and amblyopia. There's also a question of minimizing nystagmus. That's one of those big features. And there's a lot of debate here. Some studies in the past have shown that you might be able to improve visual acuity by doing a surgical procedure to treat their nystagmus. Although some more recent studies have actually measured visual acuity in different directions of gaze, so kind of comparing visual acuity to when people are in their null point versus when their nystagmus is really severe, and actually haven't found a really good correlation between visual acuity and nystagmus severity within the same individual. So this kind of brings up the question of how helpful nystagmus correcting surgery on its own might be. I would also encourage people to consider genetic testing. I think for a lot of patients, this is really helpful to have a genetic diagnosis. It just kind of helps give them clarity if it does. Obviously, I talked about a lot of the caveats there, but I think sometimes that can help inform the whole clinical picture of what might be going on. Certainly referring to low vision resources as needed. Not every patient needs this. Some patients are 20/25 or 20/30, and they might feel like they're doing great. But if they are one of those folks who has really low visual acuity, then they might really benefit from low vision resources. One of the things I've wondered about, but don't have a lot of experience with, is thinking about FL41 lenses, because a lot of these folks do experience really significant photophobia. And so this might be something, I know since we offer these lenses a lot, and for other conditions, it might be something that we can trial for patients who are struggling with the photophobia, so they don't feel like they have to wear sunglasses indoors. And I also want to emphasize some really thoughtful patient counseling for these patients. I've talked to a lot of patients and families who maybe got a diagnosis when their child was really young, and they tell me, oh man, I took my child into their optometrist or ophthalmologist, and they told me my kid was going to be blind and that they're never going to drive. And that can be really devastating for a family, when we know that a lot of these kids don't grow up to have really poor vision. A lot do have really good vision and might live really normal, not visually impaired lives. And so I think it's really important not to overwhelm families with this definitive, really devastating visual diagnosis, and let them know that there's a lot of room and there's a lot of variability there. The other thing that I really want to emphasize is, you might have noticed during this talk and other talks that I've given, that when I'm referring to patients with albinism, I never use the term albino. And that is actually something that the albinism community has specifically asked of us, that we don't use that term and rather talk about them as people with albinism or patients with albinism. This is a trend that's going on in a lot of other kind of medical diagnoses and communities. And this puts the patient before the disease and before the condition. There's a lot of different kind of connotations with the term albino. And so this is something that I think can really help patients feel seen and supported. So I'm running out of time here, but I do want to talk about some resources for patients, and especially highlight the National Organization for Albinism and Hypopigmentation, or NOAA. This is a really big patient advocacy organization that is really well established. They've been around a long time, and I think they do a really good job of addressing needs at different stages of life, and also needs for groups, patients who are coming from different racial and ethnic backgrounds as well, and what that looks like for them. They do a conference every other year that's super fun. A lot of these kids with albinism see this as like their biannual summer camp that they go to, and they have all their friends that they see every year. And so I think that it's really good to connect patients with this. The website is just albinism.org. And so they have some really good resources there. And also, I think connecting patients with research studies can be really helpful. A lot of these folks will say, I know there's no cure for albinism. I know that, we can't improve my vision, but if I can contribute to other people benefiting from research, they get really excited about that. So I know I did my doctoral dissertation research at the Medical College of Wisconsin, and that's a place where they're still doing ongoing research on albinism and often have money to fly patients out to participate. We worked a lot with colleagues at the University of Iowa, particularly Dr. Arlene Drack, who's an IRD specialist there. And then I'm also getting an albinism study going here. So if anybody has patients with albinism or people you think might have albinism, you can let me know and I'd be happy to include them. I was going to talk about a couple of cases, but I think we're out of time. So with that, I will kind of show these conclusions here, just kind of pointing out that albinism is likely highly underdiagnosed. So just kind of keep this in mind if you have a patient who's not correctable to 20/20 and maybe has foveal hypoplasia on an OCT. Make sure you're considering those genetic test results carefully as well, just because a lot of these hypomorphic alleles like R402Q are not often reported on results because they're thought to be not pathogenic, but sometimes can be helpful in making a diagnosis. And what they hear from you matters. So just, again, be thoughtful about what you're telling patients when you're giving them that diagnosis, and make sure that they really feel empowered with some of these resources. And with that, I want to thank you guys for your attention.
In the meantime, I wanted to announce our last speaker of the day. This is Ayesha. She's one of our wonderful, wonderful medical students, fourth-year medical students. And her fun fact, we just came up with it this morning, is that her current obsession is matcha, including colors like her outfit if you see today, her phone case, and also the tea and any food that has matcha in it. So thank you, Azraa. Come on.
Hi, everyone. Good morning. I'm Azraa. I just spent a month on the Neuro-Ophthalmology elective, and so I wanted to do a very short but sweet presentation of two interesting cases I saw this month. All right. So first off, this is a patient that I saw with Dr. Warner in her clinic. This is a 22-year-old female with a history of craniopharyngioma and a meningioma that was diagnosed at the age of 2. Although I unfortunately don't have imaging, her craniopharyngioma was compressing her optic chiasm, and she required emergent surgery when her parents noticed that she was unable to see things directly in front of her. She luckily had a pretty good outcome post-op. Her visual acuity recovered, but she did have persistent visual field defects. So for the past 2 decades, she has had a persistent bitemporal hemianopia, as you can see with her visual fields here. She was previously followed by Dr. Jardine and now Dr. Warner, but in the past 2 decades, she's had this stable, close to symmetric bitemporal hemianopia. And I think what's really interesting and almost beautiful about her case here is that with her RNFL, you can see that she has nasal thinning. I won't bother. She has nasal fiber layer thinning on both sides. And so as you would expect clinically, the loss of the nasal fiber layer of both of her eyes have led to this temporal visual field defect. So I really like this case because it's almost like a perfect clinical example of an image that we have all learned in our medical training. As you can see with the kind of purple highlights of the image here, you can expect a bitemporal hemianopia when there is this compression of the optic chiasm. Specifically, as we saw in the patient, an interruption of the nasal fibers of each eye, like we saw in our patient, would lead to this temporal field defect. So very beautiful clinical presentation of this patient here. My next case is the one that I saw with Dr. C at Mid-Valley Clinic. This is a 36-year-old male. He has a history of hypertension, intermittent cocaine use, and notably a BMI of 40. Worth noting is that he's uninsured, and so his last visit with primary care was about 15 years ago. But the reason he was here today is because he was very bothered with this sudden onset of binocular diagonal diplopia that suddenly came on 5 days before while he was driving. It had been constant in nature, so he had been patching ever since. And he noted that at times images were bouncing or rotating around. He hadn't noticed this until he arrived to clinic, but he had trouble with his upward gaze. And lastly, he mentioned he had been stumbling more and had headaches, and he attributed all of this to the double vision. For his pertinent exam findings, his visual acuity was all right. Left eye wasn't so great, but notably his pupil exam did have minimal reaction of the right eye, and then the left eye had a very sluggish reaction to light, although both of them had a near reaction. No APD. And for the extraocular movements, there was a deficit of about -2 with the elevation of both eyes. And lastly, something that we noticed on exam, unfortunately I don't have a video, is that he had this torsional nystagmus that was worse with upgaze, also known as convergence retraction nystagmus. And so, as you all are probably guessing, these findings were correlating with dorsal midbrain syndrome or Paranose syndrome. And specifically, there was an acute concern for either a tumor, demyelination, or ischemia to the brain. So pretty eventful. This patient was transferred immediately from the Mid-Valley Clinic to the ED for concerns of the central lesion. And he had an MRI brain, which showed that he had infarcts of his left PCA territory, specifically of the left thalamus and the left occipital lobe. It was suspected that these were embolic because once he was admitted to neurology and treated for a stroke, he was also diagnosed with diabetes, as he had an A1C of 10.5 at the time. Very quickly, I just wanted to touch on paranoid or dorsal midbrain syndrome, as this patient was an excellent presentation of the triad associated with this. Specifically, this dorsal midbrain syndrome is most often caused by pineal region tumors, brainstem hemorrhage, or an infarct, third option being what we saw in our patient. The triad that you'll see in the clinical presentation of these patients is that they'll have up-gaze palsy, convergence retraction nystagmus, and a light near dissociation of their pupils. And these things particularly happen because all structures relating to these are located in the midbrain. Specifically, the MLF is responsible for that up-gaze palsy in the midbrain. And then midbrain supranuclear fibers are disrupted, leading to that convergence retraction nystagmus. And lastly, for the light near dissociation of the pupils, that can be attributed to the impact on the Edinger-Westphal nucleus, which is also in the nucleus, or sorry, in the midbrain. And interestingly, 87 to 100% of patients will present with this up-gaze palsy. It's the most common symptom, but only 65% of patients will actually have the full triad. So this was another great case where the patient had all three. And that was it. Thank you all so much. Thanks for a wonderful month.